episode of this new series that we are calling OncoSnacks, bite-sized snippets of information that aim to lend a more practical helping hand to our listeners regarding issues that are commonly encountered in oncology.
Michael, I'm hungry to hear what we're talking about today. What's our topic?
Well, you won't be hungry after you hear the topic because it is diarrhea.
Is there any specific type of diarrhea or just general diarrhea?
Just in general. I just thought we'd talk about diarrhea. No, we'll talk... We'll talk about chemotherapy, specifically chemotherapy-induced diarrhea. There's the elephant in the room, which is immune-mediated diarrhea, but I'm sure that will be another episode. As you've probably heard, the hosts haven't changed. I'm Michael, that's Josh. We're two oncologists / oncology trainees / I don't even know what we are anymore. And we are having so much fun making our other podcast, Oncology for the Inquisitive Mind, # go check that out, that we figured we'd do a second one. We just can't get enough of you lovely people listening to us.
So excited to talk about diarrhea, Michael. And let's frame it, I think.
No one wants diarrhea framed, Josh.
I have had pictures sent to me.
There's modern art and then there's that.
Let's talk about this. You are the oncology trainee. You might be a medical registrar. You might be the resident or even a new consultant, and you just haven't dealt with diarrhea-induced chemotherapy in a while. And you're on call and you have 5 patients that have come through ED in that 24-hour period. They're all on some variation of treatment, chemotherapy. Their numbers range from 2 to 15 episodes of diarrhea, and no one can keep a good diary of how much diarrhea they're having.
A diary, some might say.
Let's talk about that, and then we'll use that as our framework for the management section. But before we talk about management, let's talk about causes.
Sounds good.
Briefly mention it, Michael, but tell me, what are the main chemotherapy agents that you've used that might lead to diarrhea?
Well, unfortunately, Josh, it's bad luck for anyone who's got colorectal cancer because the agents that tend to cause diarrhea, in my experience, are the 2 agents that frequently form the meat of chemotherapy regimens for colorectal cancer. That is fluorouracil, or the fluoropyrimidine, so 5-FU, or its oral prodrug capecitabine, and irinotecan. Now, together, they make FOLFIRI. They're also involved in FOLFIRINOX, or FOLFOXIRI, for pancreatic cancer. The irinotecan is used as far afield as for small cell lung cancers in the second-line setting. So very, very commonly used drugs, but most commonly seen in the colorectal space. These people might already have disordered bowels, so they're naturally sitting ducks for diarrhea.
Exactly. And the mechanism is a little bit interesting, Mikey, and I might briefly highlight that.
Please do.
Thank you. I'm going to just lay it out. There are 3 different pathophysiological mechanisms that happen. The first is increased secretion of electrolytes. This caused by luminal secretagogues. Synagogues, or reduced absorptive capacity due to surgery or epithelial damage caused by chemotherapy drugs themselves. So that's called secretory diarrhea. There's also then increased intraluminal osmotic substances leading to osmotic diarrhea or altered gastrointestinal motility. In general, secretory diarrhea is characterized by continuous despite fasting and associated with stool volumes of greater than 1 liter per day. Now, fluorouracil and irinotecan both cause damage to the intestinal mucosa, leading to a loss of epithelium and secretory diarrhea. Approximately 10% of patients with fluorouracil or FU have decreased expression of enzyme lactase in their intestinal brush border, leading to lactose intolerance and causing osmotic diarrhea. So this is actually really interesting, isn't it? Because there's multiple mechanisms involved.
It's very interesting, and I must confess, whenever I'm confronted with a patient who has diarrhea, I've never asked, is it worse with dairy products and milk? I certainly will in future because it is interesting, but I've never even thought of iatrogenic lactose intolerance.
That's it. And I didn't mention irinotecan. You can't spell irinotecan without an I.
That's terrible.
Thank you. So irinotecan Diarrhea is cholinergically mediated, so related to increased motility. By contrast, later irinotecan-associated diarrhea is not cholinergically mediated, but instead appears to be multifactorial. And everyone's like, Josh, stop it. I don't want to hear multifactorial. It's a terrible cop-out. But essentially, you've got dysmotility, secretory factors, as well as direct toxic effect on intestinal mucosa. So we know what drugs cause it. We now know how it works, which is amazing when you want to tell the poor patient in the bed what's happening to their gut.
Yes, just give them a lecture on diarrhea while they're absolutely miserable. Well, look, I mean, we are talking about diarrhea as if it is a inevitability or a known quantity that there isn't something else going on. I do have a case on our wards at the moment of a patient who initially was thought to have infectious diarrhea because we isolated E. coli in his stool sample. And the plot thickened. It turns out he probably has immune-mediated colitis because he had immunotherapy previously. But the most important thing is to keep an open mind. So always do a stool sample, a fecal microscopy and culture and sensitivities, because you will be surprised the patient who the story fits. They've just had chemo sort of 5 to 7 days ago, or in the case of irinotecan, you can have delayed diarrhea as well, so it could be a few weeks ago. And you say, look, it's the chemo, and then you do the sample, and they've got Campylobacter or E. coli or something. So always do that because the management is different. You can't give someone with infectious diarrhea slowers because you're putting them at risk of horrible complications like toxic megacolon. So that's the first step. The second step, though, is really to get a sense of the severity. And really, the crux of this is quite similar for our sort of general physician colleagues and anyone doing their training, is how much are they going, how frequently are they going, how much volume are they losing, and what are the effects of that. So obviously, if someone has just mild diarrhea, they might be going 4 or 5 times a day when they normally go once. They're still not significantly dehydrated, their end organ function is preserved, they're not otherwise unwell, in which case the management is usually just supportive. If you want, you can give them some intravenous therapy if they happen to be in hospital, but you can probably manage them as an outpatient, give them some slowers, whatever the opposite of a laxative is, Josh, but you give them an agent like loperamide or codeine, to try and slow down the transit of the diarrhea through their body. And generally, that's all they need, because if it is chemo-induced, that drug will get out of their system eventually. And once the drug is out of their system, then the symptoms generally subside. So you can just manage it symptomatically and supportively. But Josh, what happens if they have complicated diarrhea, so severe symptoms, associated nausea and vomiting, sepsis or fevers, neutropenias, dehydration or end organ function like acute kidney injuries? What do you do then?
There's a number of factors here. So you've admitted the patient, you need to make sure you stabilize them. So you need to rehydrate as a start. You need to cover them with intravenous antibiotics. You know, they're neutropenic and they've got sepsis. You've got to worry about neutropenic colitis. You've also got to then worry about perforation. If they perf, that's a terrible story. You're going to want to get an image of their abdomen. You want a CT ASAP, because if they're getting sicker, you have to ask the question, do they have a collection? Is there something you're not seeing? Is there a perforation? You know, has the damage been done? Do they have pancreatitis? Not that pancreatitis causes diarrhea, but you can definitely get both. And I think that's probably the next step. So, you know, you bring them into hospital, you know how many stools they've got, you've given them loperamide, and you want to make sure you just kind of try and manage that as efficaciously as possible and as safe as possible. The other thing is make sure if they're on, let's say, capecitabine, they stop the capecitabine. Sounds simple, but it's very important to stop the offending agent.
Absolutely, and that is something that is so easily forgotten. They definitely need to, because I've had patients, and I'm sure you have had, Josh, where they have diarrhea in the community, you're giving them all this advice, and amidst all of it, they're still taking the offending agent. So very important.
The other drug you can use that I've sometimes used is diphenoxylate atropine, so Lomotil. Have you ever used Lomotil, Michael?
I've never used dihymetra thingy.
Diphenoxylate atropine. So Lomotil I've also used. I've used them predominantly actually in the TKI family when loperamide doesn't work, because I find stopping the agent is generally the best therapy for these patients. And I have not used octreotide very often. Have you?
I've used it a handful of times. I don't think it's really ever worked, but it is for those people that have really refractory diarrhea, where they're on maximum dose loperamide, maximum dose codeine, and they're still not having a good outcome. So it's a bit of a last gasp agent. But what you said before is interesting, because I don't think we mentioned it, is that the other causative agents for diarrhea are the TKIs, are usually reserved for renal cell cancer, but they do cause horrific diarrhea.
That's it, isn't it? And I think there's a couple of other, this is not medical advice. There's a couple of other, we should put that in the preference.
We should put that in a preference. This is sort of for educational purposes only, etc. Please don't sue us.
So other options that I've seen use budesonide as well. So it's an oral steroid tablet. I've definitely used that a lot in Gen Med, not so much in the chemotherapy world, but you can use that. Things like probiotics as well. They're probably the other main ones that I've sort of seen with my patients. And of course, DPYD testing as well is something really important. If they don't break down fluorouracil or capecitabine properly, you really want to know about it. Predominantly, we mentioned this previously in our talk, but it predominantly affects Caucasian people. I think it's about 5% incidence, depending on where you work. Some people will test it all the time. Other people won't test it at all. That's probably just something else to highlight, Michael.
Yeah, but it is something that is worth highlighting. And I think we mentioned this in our first episode on mucositis, is that there is a constellation of symptoms that makes you worried about DPD deficiency. It's normally very rapid onset, because it doesn't take much for these patients to accumulate very toxic amounts of the drug because they're not breaking it down. It is usually combined with horrible mucositis, diarrhea, torrential diarrhea, and horrible cytopenias and hand-foot syndrome as well. So you take the usual side effects of something like capecitabine and turn the dial all the way up to 15. And that is really how it. Thank you, Josh. That is really how it presents. So so very much something to consider. The test is probably about a couple of $100. The antidote in Australia, I think, is in the tens of thousands, because we don't actually have it on our continent, on our great southern land.
And we're pirates.
Yeah, we're not pirates, but I think we actually have to get it flown from the UK to here, by which time it's frequently too late. So very much worth treating. And obviously, I guess you have to, you've summarized it very well, Josh. You need the CT, you need all of the supportive measures, and then you need to sort of monitor their end organ function as well.
When we talk about supportive measures, I didn't mention this, but electrolyte replacement is huge. So magnesium, potassium, you're going to lose huge amounts of that, probably phosphate as well. And you just need to pump them full of it. Make sure it happens. A lot of our oldies will then go into AF, and you've got to manage that. And the other things with the stool sample, make sure you look for viruses as well, and Clostridium difficile, which is everywhere.
Particularly if they've had a recent course of antibiotics. Mm-hmm. You drag the patient kicking and screaming through their horrible episodes of diarrhea, and you get them home. But what changes would you generally make to their chemo? Because you can't really, unless you have something like DPD deficiency, which is an absolute contraindication, you can't stop the treatment. So you need to finesse it a little bit. What do you do, Josh?
I think, so if we go back to my initial scenario of 5 patients that have all come through ED, you need to look at, first of all, what's the objective of your treatment, right? So is the objective curative versus palliative? Because your approaches might vary. You have to figure out how long do they need the treatment for, but generally you're going to be having a conversation depending on the severity about management. So either prophylactically taking some slowers as we're going to call them for this episode.
Yeah, just slowers.
Just slowers, or you're going to dose reduce them to try and reduce that risk of having severe diarrhea, because you want them to complete treatment, especially in the colorectal sphere. 3 months you can give them Capox, or sometimes 6 months Folfox, depending on sort of their risk and of recurrence. But remember that stage 3 colorectal cancer, we mentioned this previously, with just surgery, 50% chance of recurrence. So that's high. So you want them to have chemotherapy.
Yeah, and I think we say this all the time, and it is a bit of a cop-out, much like Josh's multifactorial comment from before, but you do need to tailor it to the patient. You need to tailor it to, as Josh said, the intention of your treatment, but also you need to tailor it to the severity of the side effect. So if it's a fairly mild side effect, you can probably re-challenge. Some people will even be really aggressive and re-challenge at the same dose, or you can give them a slight dose reduction. If it's really severe, you need to have a significant dose reduction and be very careful if you want to escalate again. And as Josh said, you might even need to think about canning or moving on to another regimen that is not going to cause such significant gastrointestinal toxicity.
So in summary, if you are a first-year advanced trainee and you're sitting fielding calls about multiple patients in ED with diarrhea, and this is a personal sort of anecdote, we did 5 CTs on 5 different patients. It didn't show anything bad, but I'm glad I did that, because great learning experience to know that if you're worried, do a CT. And we're oncology, so you can kind of say, I need a CT because we're worried, and they will do it. And if they don't want to do it, just say, here are the 6 potential risks that you have of not doing a CT. So I think the summary, Michael, I might take us out from OncoSnacks because we're over our 15-minute limit. We have talked about colitis and diarrhea in the context of chemotherapy, which doesn't happen to everyone, can be quite debilitating. Remember, the tenets of any management is to figure out the cause, so send off a stool sample, manage the symptoms, so slow down that diarrhea, replace the electrolytes, give them all the supportive care, and don't forget, if you need to image or ask for help, you can.
I think that's an excellent summary, Josh. And as promised, that is our snack-sized episode on diarrhea, completed in, it's 18 minutes recording, but if we cut it down, it should be around 15 minutes. So you're welcome, everybody. Join us next time on OncoSnacks, where we'll talk about chemo-induced nausea, how to treat it, but critically and probably more importantly, how to prevent it. We'll see you next time.
See you then, Mikey. Bye.